And welcome to our live stream. It is now September, what is today? 26, 2023. I'm Dr. Ara Deuk, CEO and founder of the Deuk Spine Institute. Our first surgery for today, September 26, 2023, is a patient with 2 herniated discs in his neck. C5-C7, C6-C7. They're causing neck pain, pain in his arm and shoulder, and radiculopathy. Ready? And let's do our first discogram shot. All right. Now just take another shot. All right. Show us, Jordan, with the X-ray machine, with the X-ray count for us. C2, 3, 4, 5, 6, 7. So we are currently at C6-7. You can see a tear in the back of the disc. You see the black line just below his arrow, right there.
Yes, we do.
That thick black line is the annular tear, and it's letting dye leak out. Shot. There we go. We've got our guide wire in. We're going through the front of the neck. This is the right way to fix a herniated disc. Herniated discs are in the front of the spinal cord and nerves. Therefore, the proper treatment should be through the front of the spine. There are surgeons who try to do foraminotomies in the back of the spine for cervical. It's horrible. Bad surgery. They're going to be removing muscle, bone, and ligaments and joints out of your spine. Don't let them do it. It's permanent damage to your body. This surgery doesn't do any permanent damage except it makes a little scar on the skin, 4 millimeters. I did not yet make the incision. It's hard to see. The angle of the light always does the same thing. We keep making the same mistake every single surgery, Luis. It hits my hand and it creates a shadow and I can't see. You've got to bring the light in from a little more superior.
Turn on that one, please.
I don't understand. We've been doing this surgery 17 years.
Thank you.
I need to be able to see where I'm cutting. Okay. This light can be brought here. Try it. There you go. That's the whole point of the handle. There you go. See? It's magic. And then I can actually see. 4 millimeter incision. Beautiful. And the surgery is essentially a bloodless surgery. We lose a few drops of blood and that's about it. Unlike open spine surgery where you lose thousands of drops of blood. Shot. You want to watch your guide wire and make sure it doesn't go back any further than ours is. Looking good. All right. Right now we're using our guide wire. Shot. I've pulled it back just a little bit. Shot. Got to keep an eye on the tip of your guide wire. Make sure it doesn't shot. Go forward. Forward is in towards the patient's spinal cord. Shot. Sometimes the guide wire will get trapped between the dilator's opening and the guide wire, and a piece of tissue will get in there and it'll force the guide wire backwards. You don't want that happening. All right, we've lost about 3 drops of blood so far. The entire surgery shot AP will be done through a 4 millimeter incision in the skin. 4 millimeters. That's about 1/8 of an inch. A little bit more than 1/8 of an inch. Perfect. You can see we're in the middle of the spine. And his herniation is off to the left side. So I like to start on the right side to get the best angle for left-sided herniations. All right. We're going to advance our dilator into the disc. Perfect. Take the guide wire out. Shot. And I'm going to just gently tap my dilator to the back of the disc. I'd like it to be a little further back. We're a little off on orbit at that, but it's okay because there's a little rotation happening between 6 and 7. And if I compensate for that now, then I'll be off on 5-6. That's perfect. The whole surgery here, folks, endoscopic, will be done through a tubular retractor that's 4 millimeters wide. 4 millimeters, okay? And the beauty of this surgery is that it's basically bloodless. There's no scar tissue. There's a tiny cut in the skin. There's virtually no bleeding, no hospitalization. It's a very safe surgery. Shot? It's called endoscopic spine surgery. Now, the next step is going to be for me to advance the tube. Show us the tip of the tube. Remember, this is the front of the spine where the arrow is. Show us the back of the spine. That's the back of the disc. Show us the back of the spine. Further back. Yep. So we're going to be moving the tube from the front to the back of the disc. There we go. Nice job, Jordan. Shot. I'm using an X-ray machine to watch. Now you see how the dilator went forward? We got to be really careful about that. We don't want that dilator moving too far forward. Shot. So I'm pulling it back a little bit, just for now. You constantly have to monitor, shot, with the X-ray, shot. Otherwise you can get into a lot of trouble with this stuff. After all, this is spine surgery. So you want to be very careful as a spine surgeon not to cause any harm to the patient. That's our number one goal, is to treat without harming our patients. And I'm just fine-tuning things right now. I really want my tip of my tubular retractor just a millimeter further. Shot? I think that's going to be it right there. Nice job, Luis. Whoever pulled the shoulder, thank you. We're done. So you can see the tip of the tube. Jordan, show our audience the tip. And let's count from C2, 3, 4, 5, 6, 7. We're fixing 2 discs today, 6-7 and 5-6. 5-6 will be the next one. We're starting with 6-7. You can't fix the 2 discs at the same time. We have to pick one to start with. Now let's show the audience here, Henry. Look at this beautiful incision. Can you see this?
Yes, we do.
All right, so look at this. Here's a tape measure. Can you see the tape measure?
Of course.
It's 4 millimeters. You guys see that? 4 millimeters.
Yes, we see it.
So this is the future of spine surgery. You're seeing it today at Deuk Spine Institute. This patient's other options would have been a metal disc in his neck or a metal plate. And he didn't want either of those, so he traveled here. Where did he travel from? Michigan. That's what I thought, Michigan. He traveled from Michigan. We get a lot of patients from Michigan down here in Florida for the Deuk laser disc repair. They don't have this treatment in Michigan. They only have metal. And there's lots of doctors around the world that are willing to fuse people or put metal discs. But I used to do a lot of those surgeries, and then there's a piece of herniation right there. Then I learned how to do the endoscopic treatment from the Koreans, South Koreans. They were the first in the world. Why is the laser turning off? You're not turning it off, right? No. Maybe the pedal position. I'll have to check it. I can do that. Just give me a second. All right, so I'm using a combination of laser energy to free up herniations that are scarred to the annulus. Yeah, the pedal should always be just north of the foot of the bed. Okay? Scope looks good, really good. Nice image. I think we're a little bit overexposed, but maybe one click reduced exposure. You can see we're at the back of this disc, and I'm seeing soft disc herniation. Soft disc herniation means this is a recent herniation, not an old one. Come on. Now this procedure uses a few things. It uses a laser fiber, which you see there, which is a 0.5 millimeter laser fiber. And that laser fiber is attached to a laser. It's about, what, 6 feet long? There's another herniation. Lots of herniation coming out. How long is our laser fiber? Huh? 9 feet. All right. All of these are individual pieces of herniation. This is what the spine surgeons are supposed to remove right here, nothing more. And yet, with our conventional surgeries like fusions, we're not taking just the herniation out. We're actually taking the whole disc out. It's called a discectomy. And the problem with that is when you take the whole disc out, then they put a cage in there made out of metal, and now you got a metal cage in your neck and a plate. And what that does is it creates a lot of scar tissue and damage to normal structures around your spine, like your esophagus, your trachea, your bronchi, your strap muscles, your sternocleidomastoid muscles, your nerves, blood vessels. All of those things that you have in your neck that you need are destroyed with the surgery. Okay? Damaged, destroyed, and that's why people have to take painkillers after the surgery, because there's so much trauma from the surgeon cutting you and cutting blood vessels and cutting muscles and traumatizing the muscles. All of that trauma creates pain after surgery, swelling, inflammation. And it's that inflammation and pain that takes so long to heal from. Now with the Deuk laser disc repair, the recovery is much quicker than with open surgery, because we're not traumatizing all those tissues. We're just sliding past them. And what allows us to just slide past them, these are all herniations, by the way. Every one of them. We've already taken out about 12. What allows us to just slide past these tissues, let's show this one. Light on. Bring me that. Light on. Come on. Can you see this, Henry?
Yes, we can.
Now these aren't big herniations. Every one of them is tiny. It's only a couple of millimeters. You guys see that right there?
Yes, we can.
Pretty cool picture, huh? That is a piece of herniated disc. And everybody thinks a herniation is one piece. It's actually about 30 pieces on average, okay? And we just have to sit here and pick every one of them out. That's what we do with the laser. Any questions from the audience?
No current questions.
All right. Well, we finally got our broadcasting working again. We figured it out. Turns out there was a server that was backing up nonstop and eating up all of our bandwidth and making it impossible to broadcast. The last couple of weeks we couldn't figure it out, and finally we did. So I apologize for those of you that tried to watch surgery but weren't able to.
As am I.
Yeah. As the CEO, it's my job to apologize for everybody. Ultimately, it's my responsibility, so we appreciate everyone's patience. But now I think we're back online, and we've got the broadcasting working and the recording working, so we're good. As you can see, I keep going in and out. I was telling you the steps of this procedure, or the components are the laser fiber, which is 9 feet long, attached to a laser generator, which is at the feet. It's a big suitcase-sized machine, and it produces laser energy, which then is delivered right where I want it to, very precisely. As a matter of fact, people talk about, are lasers dangerous? No. As long as they're used properly, they're not dangerous. They're actually far safer than any metal instrument that the surgeon is just sticking down here, not able to see what they're doing, which, by the way, is what happens with an ACDF and an artificial disc. The surgeons really can't see this level of detail. So the endoscope allows a level of detail that has never been achieved before in spine surgery. It is the most detailed view. There's another herniation right there. You guys see that? It will not come out. It's too big. So the endoscope allows a level of detail to be seen we've never had before. 10 times more detail. Oh, look at the size of this one. Turn on the light. This is a much bigger piece. Check this out, guys and gals. Can you see this one?
Yes, we can.
I broke it, but again, you see what happens here. We're taking out, 2, 3, 4, 5 millimeter pieces of herniation. We're already on about 20, and there's still a lot more to go. So the average herniation is not one piece of herniation, it's probably 30. And we've never known that until now, until endoscopic surgery. Because when you're doing an ACDF, you're just scraping out what you call the herniation, but it's actually not one herniation, it's multiple, but you don't know that because you can't see it. So the fact that we have endoscopic view now inside the disc, which thanks to the Koreans, the South Koreans, Dr. Sang-Ho Lee, Dr. Gun Choi, they're the ones who pioneered this technology. At Woodydal Hospital, they're the ones who taught me. So I'm a direct first generation endoscopic, cervical endoscopic spine surgeon from them, from the creators, who discovered to use the endoscope in the cervical spine. And they trained me back in 2007, 2006, 2007, and I've taken their training to the United States. I'm the first surgeon in the United States to bring their endoscopic training here. I had to buy all the equipment. I had to make an investment. I had to learn. I had to bring all the equipment here from Europe. It's all FDA approved. But it was a massive undertaking that I invested in many years ago, and I'm glad I did, because this surgery is far better than what we're offering people in the United States. And we are in the United States, obviously, but most spine surgeons, they're only offering fusions and metal, even though this technology has been around for 20 years. And it's a shame that they don't offer their patients less invasive treatments. But these surgeries don't pay very well, and so they're not motivated, even though I've gone and taught them all how to do the surgeries, shown them, published. They still choose to do fusions, which I don't think is in the best interest of patients. So we're here teaching the public directly that this treatment is available for you. You don't have to settle for a barbaric surgery like a fusion. Okay? The problem is, of course, number one, the surgeons have to learn how to do this procedure, which they're not being exposed to it because their education is being controlled by program directors. And the program directors are all being paid off by the companies that sell metal, screws, rods, cages. So when your chairman of your department or your head of spine surgery is bought and owned by companies that sell metal plates, cages, screws, rods, and that chairman is the one who determines what kind of surgeries are being done at that hospital, all of the residents learning and training, they're only going to learn how to do those metal-based surgeries. And this has been going on for 20 years now. We've had this technology. And it's a shame that people are not having more access to it. And the reason is, unfortunately, the surgeons. But it's not just the surgeons. It's really the insurance companies are to blame. The surgeons are to blame. the anesthesiologists are to blame. I'm just kidding. Just seeing if my anesthesiologist is awake. I was waiting. Look at all the herniations coming out, by the way. That is a tear, for those of you who are interested. That's called the posterior longitudinal ligament. And you can see the herniations behind it, sitting against the spinal cord. So I got to open it up and get these pieces of herniation out, because they're sitting right there on the spinal cord. This is as beautiful anatomy as you're ever going to see. You don't see this detailed anatomy with ACDF or artificial disc, because they don't do endoscopic surgery. You can't see this level of detail. This is unique to endoscopic surgery. Because you can have the endoscope, because you're doing endoscopic, you can see this detail. I can literally peel away 1/10 of a millimeter at a time. Remember, these herniations are about 2 millimeters, 1 to 2 millimeters. And my laser is literally, look at this, it's peeling away 1/10 of a millimeter at a time. By the way, that fiber right there is 5 millimeters. Sorry. Yeah. No, not 5 millimeters. Half a millimeter. 0.5 millimeters. Look at that herniation that just came out from the epidural space. Okay. The fiber that you guys are seeing, the glass fiber, is 0.5 millimeters. So I'm able to peel away 1/10 of a millimeter. How many of these do we have?
We have around 6 of them.
We need more. Can you order them from Germany?
It's a different company.
Yeah, it's a different company, but order. Let's order another, they're about $1,000 a piece, I think, or $1,200 a piece. Order another 4. People always wonder, why is surgery so expensive? Well, we ask the same question. It's because all the equipment and supplies are so damn expensive. We don't set those prices. All right, that looks really good. Nice and clean back there. Almost done on that side. So just to give you an anatomy lesson, the beige on the right and left is the bone, the end plates, the back of the vertebral body. All right, we are literally at the back of the disc, and that white fiber down there is the posterior longitudinal ligament. And I'm going to cut through a little more right there. And the reason I have to cut through it is to release the herniation behind it, I have to cut through it with the laser. You cannot do this, by the way, without the endoscope. So endoscopic surgery has made cervical spine surgery so much safer and better. And I was telling you that that laser fiber is literally 0.5 millimeters thick. 0.5, not 5 millimeters, 0.5. So the peeling I'm doing with the laser right now on the PLL is literally 1/10 of a millimeter at a time, okay? Which is the safest surgery in the world, as long as you know what you're doing, for a herniated disc, okay? So when you read these stories about surgeons that are bashing laser surgery, they have no clue what they're talking about. They've never done laser surgery, and all they're doing is criticizing it. Me, on the other hand, I spent 26 years doing fusions and artificial discs. I have a lot of experience with those procedures. As a matter of fact, I've done 1,000 ACDFs in my career, and artificial discs. As a matter of fact, when I was in training at the University of Florida in Gainesville, Shands Hospital, top neurosurgery program in the world, back in the 90s and early 2000s, we were a test center for the artificial discs. Okay, we were putting them in as part of the FDA ID studies for the United States to get FDA approval. We saw the complications, and there were a lot. And I will tell you this, the companies hid the complications from the public. They would not publish the results. They would cut the patient out of the study rather than publish the result. Okay? I am not sworn to secrecy to protect the interests of the implant company. I am sworn as a doctor to uphold the Hippocratic Oath, which is to protect patients. And I will tell you, there was a lot of cover-up going on with the early FDA studies for the artificial discs in the United States, just to get them approved so these companies could make billions of dollars selling them. Okay? Then they would publish them to be as safe as fusion, and they would show fusions with complication rates of 15-20%. We never had those complication rates with fusion. They were manufactured complication rates. Hey, what are you doing?
Oh, yeah.
Manufactured by the implant companies. Okay? But they were never that bad. All right, I've gotten about as much as I can get over to that. Another thing, by the way, for those of you who ask me, can you get 100% of the herniation? Absolutely not. I tell patients, don't expect your spine to look normal after surgery. There is no spine surgery in the world that's going to make your spine look normal. The goal of surgery is to treat symptoms. And if you can fix the patient's symptoms, make them functional, get rid of their pain, their weakness, their numbness, things like that, then you'll never make the disc look normal, so don't expect it. You'll never get 100% of the herniation, so don't expect it. But you can relieve symptoms. I've gotten as much as I can get out of that foramen. I think we're done here. I've gotten about 70% of the herniation. The other 30% is just not possible. And if you try to get more, you're going to end up hurting the patient, because there's a limit to what you can do surgically. If you think about it, you're really operating in a room, like a little room, and you're limited by the walls of the room. You know, this is what we call the surgical field. And every surgeon has that limitation. It's just with endoscopic surgery, you have less limitation, but and less damage to the walls, so to speak. All right. Let's bring our fluoro in. We're going to take this tube out of this C5-C7 disc. We're going to move it up to C5-C6. Any questions?
Yes, we have a couple of questions.
Before we do that, let's run our video on why do herniated discs cause neck pain. Let's start with that, then we'll come back to the questions.
Copy that.
All right, welcome back. We are migrating our dilator from C6-7 disc up to C5-6. This is the hardest part of the surgery. I'm off of midline at this point. Got to make my way back. And one of my secrets for the future generations of endoscopic surgeons is muscle relaxation. Shot. Muscle relaxation is utterly essential to successfully navigating against the muscles. Shot. Lateral. So now I'm in the middle. You see the spinous process there? All right.
Yes, we do.
Yeah.
Okay, I got to make it north just a smidgen more. Shot. And by the way, my hands are getting radiated by radiation. It's one of the sacrifices AP we surgeons do as part of our job. We take radiation. We put ourselves in harm's way for our patients. Nobody really talks about it, lateral, but it's a fact. I'm the closest to the radiation besides the patient. Now the patients, they get a dose of radiation, but one dose of radiation in your lifetime, 1 or 2, is not a big deal. A surgeon, spine surgeon, you're getting it every day. So it's a sacrifice we make that we don't talk much about. Shot. I feel like I'm on a bone spur right there. All right, shot. Yeah. So this is maybe you could pull the head just a little bit, but let me make sure I'm in the middle again. I am definitely fighting his muscles a little bit. No. 2, 3, 4. We're going to be done shortly, and I don't want to make his recovery difficult. Shot. AP. So we're back, I take it, Henry.
Of course, yes.
Lateral. Yeah.
I wanted to give a shout out to a good friend from New York City.
All right, we got a shout out from Dr. Berndes.
Shout out to
Just give me a second. Let me just verify the position. That looks good. All right, go ahead, Dr. Berndes.
Shout out to Andy watching from New York.
Shout out to Andy watching from New York City. That's from Dr. Berndes, our anesthesiologist. Anesthesiologist to the stars. All right, at this point, we can do what's called a discogram, which we did the first time. I'm going to clean out this dilator shot. Perfect, yeah. That's the most important thing when you're sterilizing and reprocessing, is to clean that bore out. If you don't, bad things happen. All right. Let's go do this discogram and shot. There we go. Show us the tear there, Jordan. You guys see the tear where the dye is leaking out the back of the disc into the epidural space, right there.
Yes, we do.
All right, perfect. So at this point, I'm going to advance my dilator to the back of the disc. This is number 5-6. Can you count for us, Jordan? Tube. 2, 3, 4, 5, 6. So we're at 5-6 now. We already did 6-7. I'm going to put my tube back over. Remember, it's 4 millimeter external diameter tube, which means the internal diameter is about 2.8 millimeters. So the entire surgery is being done in a space that is 2.8 millimeters. That's why patients don't have problems after the surgery. We're not tearing up their neck doing the surgery, whereas if you do a fusion, you are, or an artificial disc, you are. Go ahead. We're going to put our fluid adapter back on. I get this question a lot. Is this surgery FDA approved? Absolutely. Everything is FDA approved here. Again, we're going to watch that tip of the dilator. That's the most crucial thing to watch as we advance the tube. It's not happy, but it seems to be not moving, which is good. Folks, we use the hammer because it literally is the most precise way of delivering energy, impact, right? I mean, you don't want to be up on the table pushing and pushing and then suddenly the dilator goes forward and give me a little distraction. Perfect. Shot, I felt it. Shot. Yep. Shot. I'll take the questions in just a moment, Henry. Just let me focus right here for a second. Shot.
Copy that.
Yeah, we're getting there, slowly but surely. Perfect. Almost there. All right, that's looking really good right there. I love it. All right, now we'll take the questions.
This first question comes from Sue on Facebook. And
Hi,
they
Sue. Welcome to our live stream at Deuk Spine. I'm glad to see Facebook is alive and kicking again.
asked, who is the gas man today?
The gas man.
Yes, man, as always, Dr. Hans Berndes.
Well, that would be normally Dr. Berndes, but I had a little gas myself this morning. I'm just kidding.
We have two guests.
Two gas men. But the one who gets paid for his gas works is Dr. Berndes, our top anesthesiologist, and just a delightful human being who cares about patients and is just the best kind of doctor any patient could ever have. We're very lucky to have him as part of our team. I hope he's here for the rest of his career. Yeah. Yep, Dr. Hans Berndes. Tell us a little bit about yourself, Dr. Berndes. Where did you train?
Trained at the University of Miami, did my internship at UCLA School of Medicine,
Trained at the University of Miami for med school.
then did surgery
Then
at UCLA.
went to UCLA and did an internship at UCLA in
Then
California.
went back to Miami and did anesthesia, finished up anesthesia at Miami.
Uh-huh.
I spent,
That's too fast for me. Went back to Miami
right,
and did his anesthesia residency.
and then did 25 years in private practice anesthesia in Las Vegas, Nevada.
Yeah,
He had 11 hospitals, 18 surgery centers.
He went to move to Las Vegas. He figured he'd take a gamble on his life and spent 25 years in Las Vegas working at 11 hospitals and surgery centers. And when he found out about Deuk Spine Institute, he couldn't resist the opportunity to come and work with us to do great things for people. So he came here to Florida to help us out. Yeah. And you're originally from Florida. He's a Floridian. I wouldn't call him a Florida man. Now, I want you to notice something different about this disc. It's not the same as the last one. This is an older injury disc. Look at this scar tissue here. Look at the calcium. All that, and look at the bone spur right there. All that orange stuff. These are bone spurs. We didn't see this in the last disc. We're seeing it now. So what we call this is, look at that herniation that just came out of the foramen. Beautiful. Now that is a fresh herniation. Look at the spicules of tissue, like little fingers. That is not an old herniation. That is a new one. Yeah, it floated out pretty good. Let's see. All right, and I was telling you guys earlier, and I will get to the rest of the questions. Look at there, another herniation from the foramen on the left. Okay, so far so good. I want you to know, besides the laser delivering energy to the tissue to break up the covalent bonds and fragment the tissue into little particles so we can irrigate it out, the other thing that's happening is we're irrigating, okay? There's literally a fluid that's flowing through that tube. I think some of you can appreciate it. And that fluid is taking these pieces of herniation and pushing them out. So there's several things happening here with the surgery. It's not just the laser. There's a lot going on in terms of fluid dynamics and cooling of the tissues with the fluid. And then there's the laser, which delivers energy directly to these pieces of disc herniation to break them up, to make it easier to get them out. And then you've got also a very important thing called cavitation, which cavitation is basically where you where the laser creates a shock wave is really what it is, a shock wave inside the tube here, which then blasts the little pieces up and out, the pieces of herniation you're seeing, okay, shock wave. So there's a lot going on. It's not just laser energy. There's also cavitation, which is just as important, and fragmentation, of the pieces of disc, like this piece right here is a very old herniation. You see the difference? It's not spiculated like the other one. And it's very much almost like, I don't know, a piece of cheese is what I think of. Like a nice mimolette. You like that? You can tell I'm getting hungry. Huh? Yeah, it's almost that time, isn't it? The thing about food and doctors is that all the old pathologists who were really the original ones to figure out what's wrong with the human body, because they studied disease, they would name everything, every disease, after some kind of food or drink. A lot of wines and ports and cheeses. All right, we'll take some more questions.
This next question comes from Sean on YouTube.
Hello, Sean on YouTube. Welcome to our live stream.
They asked, if I have a constant tightness and knots in my SCM, is it coming from disc herniation? I have disc herniation, but they are mild. Also, I have been trying to come see you for a while now. I just can't afford it.
I'm sorry.
Do you need any furniture? I'm a woodworker. LOL.
That's awesome, Sean. Thank you so much. And I love bartering. So your sternocleidomastoids are tight. I don't know why that would be. Can it come from a herniated disc? Only when the disc is causing pain. So you'd have to have pain, and then the muscles would tighten up in response to that. I don't know why your sternocleidomastoid muscles are tight. It's a great question. I would really need to try to examine you to figure it out. But there's things called cervical dystonia, which you may have heard of, dystonia. It's where the muscles in the spine get super tight and spasm. And it's not a treatment that you can fix with surgery, if that's what you've got. So the answer is, the best thing to do is to see what's called a neurologist, where you live, okay? Neurologist. Can you write that down for him?
Not a problem.
Yeah. And a neurologist is not a neurosurgeon like me. I'm a neurosurgeon. We fix things by operating, usually. A lot of scar tissue here. But a neurologist deals with what are called movement disorders, like dystonia, which is what you may have. And I don't know if you have it or not. But the neurologist can figure that out. But what you're describing to me, it sounds like dystonia. dystonia. Cervical dystonia. And it's really what it says is what it means. Abnormal tone of the muscles. Dys means abnormal, right? And tonia is tone. A lot of scar tissue, a lot of calcium, a lot of spurring. This disc is a very different kind of disc than the last one, which was a newer herniation. This is an older injury, very old, like probably at least 10, probably 20 years old. Now there is some fresh herniation here as well. We've seen that. But compared to 5-6, this disc is spondylitic. 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 It's a fancy way of saying full of old arthritis in the disc. People don't like to say arthritis when it comes to discs because discs are not true diarthrodial joints. A diarthrodial joint is like your knee, your hip, your shoulder, your facet joints, where you have cartilage and a synovial capsule, synovial membrane, joint capsule. These discs don't have the same structures as other joints in your body. Therefore, doctors don't like to say you have arthritis in your disc. So they have a special name for it. That's a bone spur, by the way. People ask me, can you get rid of bone spurs? Yes. I don't get rid of all the bone spurs, but I get rid of the ones that need to be gotten rid of. Right? Anyway, we don't call the same process as arthritis in a hip or knee. We don't call it arthritis in a disc. We call it spondylosis. There's another bone spur. Gone. Okay? You know how you've seen the movie Gone in 60 Seconds? Gone in 3 seconds. We're even faster. All right, I think we're done here. Doctor, we're done. Sorry I didn't give you more warning, but probably just another minute or two. I'm going to clean up this foramen. That's fine. I'm okay. The muscle relaxation is primarily for getting in. Yeah. If we had another disc to do, then I'd be more concerned. But just want to clean up this last bit of scar tissue and herniation over by the foramen. Remember, you're never going to get 100% of the herniation. Don't expect it as a patient. Don't try it as a doctor. You're going to hurt the patient. I guarantee it. You'll regret it. Life is a balance. You have to find the balance. Okay? A balance between doing too much and doing too little, in surgery, that is. All right. I have to say I've never done too little. And I say that because I check my results and see how patients do. We have never had an unsuccessful Deuk laser disc repair. We've had patients come back with pain. About 10% of them do. And they have something else going on. 10 to 15%. Usually it's the facet joints that are hurting them, or if it's in the lower back, it'll be their SI joint, piriformis muscle, some other pain generator that's acting up, but not where we operated. And people have a hard time sometimes with that. They need to understand that, you know, when we target their pain source in clinic, we're getting a snapshot of one day and one moment. It doesn't mean that's every single pain they've ever had. And so we treat what we know they have. We don't treat anything else. If they have another source of pain, it's going to need additional treatment. We won't know that until it presents itself. Okay? There's no way to know based on the MRI. People ask me that all the time. Can't you just look at the MRI and tell where the pain's coming from? 100% no. If that was true, think about it. There's lots of MRIs out there, yet there's lots of people in pain. Why? The answer is simple. The MRI does not tell you where pain comes from. Patients do. I need 1 minute. All right, I'm going to come and answer your questions face to face in about 5 minutes. So we're going to run one more video right now. Oh, look at that. Beautiful. We're going to run another video explaining how the Deuk laser disc repair works. How's my irrigation? Yeah, I can notice there's a decrease in flow. It's okay. I just have to debulk the herniation a little bit. But I want to make sure I don't have anything on the other side. Less than 1 minute. Yeah, so part of our surgery, this debridement is, you can't debride something where you can't remove the pieces of tissue you're removing. They have to leave. So the debridement requires that we float out all this debris, right? After all, it wouldn't be a debridement if you don't remove the debris. All right, that's looking pretty good. Still a little bit there. My gosh. So you can see that he's got tears in his posterior ligament, both discs. There's one there as well. And this is an older injury, you can see it. But I'm literally operating right on top of the spinal cord and peeling the herniations off. All right. That's just ligament. I don't see any more herniation. Maybe that right there, a little bit. It's moving around a little. You guys see that? That's right on top of the spinal cord. This is some scar tissue. I just cannot remove any more, you know, any more, and you put the spinal cord at risk. We don't want to do that. All right. So that's why you're limited. You're limited in how much you take out because you have some structures in there that are very, very delicate, and they need to be respected and preserved. But you could see it really well, couldn't you, with the endoscopic view? You don't have that view when you do an ACDF, not even close. You're looking down a dark hole. So, all right, I'm going to come and take your questions, but I want to show you first just how tiny this incision is. This is true minimally invasive spine surgery, folks. Surgeons out there will tell you they're doing minimally invasive surgery, but you got to ask yourself, do they really do minimally invasive surgery? 4 millimeters incision is the smallest you can make. There is nothing smaller to do surgery. All right, you guys see the incision?
Yes, we do.
Literally 4 millimeters. See that?
Yes, we do.
And we lost like literally 5 drops of blood maximum. That's 1/4 of a cc. Go ahead, finish up. All right, type your questions up. I'll come answer them for you face to face. Good morning, I'm Dr. Deuk, CEO and founder of the Deuk Spine Institute, here with one of my patients who traveled from Mississippi.
Yes, sir. Oxford, Mississippi.
Oxford, Mississippi, which I've never been to Oxford, Mississippi, but I'm sure it's a lovely place.
Very nice.
And why did you come to Deuk Spine Institute here in Florida?
I'm having issues with my lower back, shooting a pain all the way down towards my elbow, as well as having a little bit of stumbling while I'm walking within my left leg, and went to other physicians to look at my spine, whatever, and they wanted to do fusion and all kinds of other nonsense that I thought maybe there might be a simpler way, a process of doing things. Did a lot of research and found Dr. Deuk here.
And what do we do for you?
You guys did a C3, I think 3, 4, 4, 5, 5, 6 at the Deuk laser disc repair surgery.
And before surgery, you had neck pain?
Correct.
For how long?
It's been ongoing probably for about 5 years.
And then pain going from your neck into your right shoulder, down your right arm?
Correct, just getting progressively worse. And that's kind of what made me finally to say I got to definitely do something about it.
Here we are less than 24 hours after your surgery, the Deuk laser disc repair. You can see the incision right here, it's 4 millimeters. And do you still have that neck pain and pain in your arm?
No, sir, zero pain.
Gone?
Gone, completely gone.
Cured?
In shock. Results better than I actually anticipated, which is a good thing, right? That's what I'm here for.
Well, I'm not shocked. It's what we expect to see typically, which is good. The procedure works, and that's why we do it. It works better than anything else. Were you offered any other treatments?
Yeah, they wanted me to go look at a what do they call a spinal deformity doctor. And they possibly looked at like doing rods and pins and, and all that kind of good, the fusion and everything. So it just kind of.
Why didn't you want to do the fusion option?
Long time recovery time, and just more of a difficult surgery.
Yeah.
Much more difficult surgery. And me working in a house, I still want to have good quality of life in the future.
Yeah. Well, fusions have complications, a lot of complications. Scar tissue, bleeding, and pain. Are you having any pain right now from the surgery?
No, not at all. Just a little stiffness when I turn left to right, but that's par for the course.
Yeah, the stiffness is going to take some time to work out.
Sure.
You've had bad arthritis in your neck. Your discs were degenerated. You had degenerative disc disease and herniations and bone spur at C3-4, C4-5, C5-6. We went in and fixed all three. You will need therapy to increase the range of motion. It'll take time and you'll get better. Are you happy with your decision to come to Deuk Spine Institute?
Very happy. I flew all the way down here from Oxford.
Yeah, very good.
So absolutely made the long trip. I fly back Saturday. And I feel much better flying on the plane than I did earlier. Just thinking, I'm not on any kind of pain medication, none of the muscle relaxant. There's zero pain, so I feel more comfortable hopping on that plane.
And we did it all through a 4mm incision. You could actually see the incision with the little tube going in to your discs. I moved the tube from one disc to the next, and we went back to the back of the disc where the tear was, and I cleaned the tears up with the laser. So that usually does the trick of getting rid of the neck pain when it comes from a herniated disc. And of course, we unpinched the nerve roots that were going down your arm. So that's why your arm is feeling better as well. I don't expect any of that to come back. You should be pain-free the rest of your life. Just don't re-injure the discs.
Absolutely. I'm definitely glad to get my quality of life back. That's the number one thing.
Anything you want to tell your audience?
Anybody that's dealing with the same issues I have, I definitely recommend to come to the Deuk Institute of laser surgery. It's a wonderful thing.
All right. Well, congratulations.
Thank you so much. I appreciate it. Thank you so much. We will. Yeah. Well, my dad lives in Tampa, so my wife's up there in Oxford taking care of her stuff up there. So worked out good to have my dad here to pick me up and drop me off at the airport tomorrow.
All right. Sounds good. Well, safe travels for you then.
Thank you so much. I sure appreciate it.
My pleasure. All right, I hope you enjoyed that testimonial as much as I did. That's one of our patients who underwent the Deuk laser disc repair, just like we performed just now in the cervical spine. And just so people can understand, what are we treating? We're treating, if you take the disc out and look at it, the disc is a cushion between bones, okay? And your bones are hard, your disc is soft, and so when you have a traumatic injury to your neck, your disc is going to be injured. Come on in, yeah. And the disc can be injured by tearing the back of the disc, which this patient had, and then the jelly from the center of the disc pushes through the tear and causes what we call a disc bulge or herniation. Hi, welcome. So this patient had two herniations in the back of his disc. You could see there was a tear, and then there was the jelly from the center is squeezed out through the back. We went in through a 4mm incision right here, went back through the disc to the back of the disc with a little tube, and using the endoscopic surgery techniques, we used a laser to remove all the herniation from the back of the disc. And there was a lot of herniation. And if you look at number 6-7 disc, the first one we did, it looked like a much newer herniation, probably within the last year. And then the 5-6 disc herniation was older. And about 90% of 5-6 was really old, probably 10 years old or older. And there was a small amount of new herniation at 5-6 where you saw a few pieces of disc herniation that were spiculated and consistent with a fresh herniation. Surgery went well. We lost 5 drops of blood. Count them, 5. You need 20 drops of blood to make 1 cc. So we didn't even lose a cc of blood. If this surgery had been an ACDF or artificial disc, it would be 100 cc's of blood loss, and there would be a lot of scar tissue, trouble swallowing, which goes on for months. Our patients don't take any narcotics after surgery. There's 0 painkillers. It's Tylenol for one night. They take a Tylenol and that's it. Sometimes a muscle relaxer. So the surgeries we do endoscopically don't involve the use of postoperative narcotic painkillers, which are dangerous, addictive, and have high potential for abuse. Other spine surgeries require those opioid painkillers. Ours do not. All right, we'll take our first question.
First one comes from Jerome on Facebook.
Hello, Jerome. Welcome to our live stream.
They asked, where is the spinal cord relative to the probe?
It's a great question. All right, so to give you an idea of where the spinal cord is relative to the probe, I'm going to take the spine and I'm going to tilt it down. Our tube was passing through the disc, sitting right in front of the spinal cord. That's where the herniation is. So we're working right here against the spinal cord. The spinal cord was about 1 millimeter deeper down.
Next question comes from PN on YouTube.
Hello, PN on YouTube. Thanks for joining us.
They ask, what does this surgery cost?
What does the surgery cost? That's a great question. I don't have the cost numbers for you, but spine surgery is not cheap surgery. As you know, spine surgery is expensive, and different types of surgery cost different amounts. Whether we're treating 1 disc or 2 or 3, it's going to cost more for the more discs that we're treating, just like any surgery. And the good news is we don't put metal or implants in, so you don't have the cost of the metal or implants like you would with an artificial disc or a fusion. But the cost always depends on the number of discs we're fixing and which area of the spine we're fixing. Certain areas are more difficult and challenging, take more time, require more resources, like the cervical spine, very expensive compared to the lumbar. Lumbar is cheaper. I can't give you an exact dollar amount though, but thank you for asking. If you want to know for yourself or somebody you know that has a spine problem, use our free MRI review, where I will sit down and virtually go through the MRI and the patient's symptoms and do an exam, and I could tell you exactly what surgery is needed, and then we could give you an exact price.
Awesome. Next question comes from Sue, once more on Facebook.
Hi, Sue. Welcome.
They asked, what is the latest technique to treat facet joint pain?
Sue, great question. What is the latest technology to treat facet joint pain? It's the technology we developed right here at Deuk Spine Institute. It's called a Deuk plasma rhizotomy. We're not using the plasma from your blood. We're using a high energy electron vapor that's generated the tip of a wand that we are patenting right now, and we use for our treatments. And basically what Sue's asking is a great question. If you look at the model here, you can see, let's see, I need to get my pointer. Seems like somebody is stealing my pointers these days. You would ask yourself, who would want my pointers? But you know, I think they're selling them on eBay. Long story short, everybody know what a facet joint is? This may be a little bit better model for you. Okay, here's your basic spine. You have the vertebral bodies with the disc between, and then you have a second joint in the back called facet joints. And you can see when there's movement, all right, your facet joints move too, right there. See that, Henry?
Yep.
Okay.
Perfect.
So what brings pain? Pain comes with movement, either disc pain or facet pain. So Sue's asking about what's the latest technology to treat facets, because right now we did a surgery to treat a disc problem. And the latest technology is the Deuk plasma rhizotomy. It's a technique we pioneered here at Deuk Spine Institute. A normal RFA rhizotomy will give you a burn of about a tiny little burn right there. You see the little red mark?
Yes, we do.
That's where the nerve runs to innervate the facet joint. The Deuk plasma rhizotomy has a much bigger burn radius. So we have a higher accuracy, higher precision, higher chance of destroying the pain nerve to the facet joint. That's why it is the latest technology. It's new. We've been doing it for by itself percutaneously for about a year. I've been doing these plasma rhizotomies for about 26 years as part of my fusion surgeries. But by themselves, we've been doing them now cervical, thoracic, lumbar, sacral. We're doing them for shoulder pain, knee pain, and hip pain. So that's why I'm wearing the hat today. Deuk Joint Institute is our new sister company. Deuk Joint Institute, we treat knees, hips, and shoulders without metal implants. It's all done with a tiny 3mm incision, 15-minute procedure, about 85% pain relief on average. That's permanent. It's amazing. It's the future of joint surgery right here at Deuk Joint Institute.
Next question comes from Siwang on YouTube, and they ask
Simone or Siwang?
Siwang with a W, and they
Siwang.
Yes, and they ask, can you explain what is a slip disc and can you treat it?
Yes. Siwang, a slip disc is the same as a herniated disc. Unfortunately, it's extremely confusing. The fact that in medicine there's 10 names for the same condition. I didn't make up these names. I was confused at first too for a long time, not knowing the difference. But a disc bulge, a disc herniation, a protrusion, extrusion, prolapse, slip disc, migrated disc, bulging disc, all of those things are exactly the same thing. They're all a tear in the back of the disc with the jelly pushing through the tear. There's just different names for them in different countries by different doctors. I'm sorry it's so confusing, but it is a herniated disc.
Next question comes from Autumn on Facebook.
Hello, Autumn on Facebook. Welcome to our live stream.
They ask, what does this do to the structure of the disc, and can this procedure help if you have had suddenly had issues with swallowing your meds daily? Feels like something is stuck in the back of the throat.
Yeah, first of all, I'm sorry to hear that you feel like there's something stuck in the back of your throat. This surgery I just did will not help that. We do not do spine surgery to fix swallowing problems. As a matter of fact, not this surgery you just saw, but most spine surgeries make swallowing problems worse. That's why you want to avoid fusions and artificial discs. If you're having trouble swallowing, you want to see an ear, nose, and throat doctor. You want to go in for an evaluation. It's possible you've got something going on in the pharynx, and that's why you want to see an ENT.
Alright, and then we got from Amartos on YouTube.
Hello, Amartos on YouTube. Welcome.
They said, I got an ACDF C5-C7 7 years ago, and until 6 months ago, I was pain-free. Now it's back to where it was before the surgery. New MRI shows intact fusion and normally really abnormal. They tried epidural steroid injection at C6, but it didn't do anything. So they basically have no clue. My scapula is hurting like someone is stabbing me constantly with an ice pick. Only trigger point injections help for a few weeks, but then it's back to the pain. What could be the problem?
All right, Amato. So if you want to know the answer, you need to come to Deuk Spine. We will tell you exactly what's wrong. What you most likely have is facet joint pain below your fusion. So that would be the joints below the fusion causing inflammation and pain. On top of that, you probably have what's called levator scapula tendonitis. That would be my guess. Levator scapula tendonitis, we're going to type it up, is spelled Levator, levator, next word scapula, scapula, next word tendonitis. It's basically a muscle that runs from your skull down and attaches to the top corner of the scapula bone, and it's gotten inflamed and like you've torn part of it off of the bone. There's inflammation, it just never goes away. You can have that for years and years. It'll hurt like hell. There is a treatment for it. It's injections right where the muscle attaches, but I think what's causing it is you have facet pain below your fusion. So number one, never get a fusion. Have the Deuk laser disc repair instead. Number two, get your facets treated properly with the Deuk plasma rhizotomy right here at Deuk Spine. And number three, get the levator scapula tendonitis injected properly and massaged and therapized properly.
And then next one comes from Nancy on YouTube, and they asked, thank you for your sacrifices, learning, and bringing this DLDR procedure to light. It's given me a renewed hope regarding my spine. Do you suggest taking collagen supplements pre-surgery?
Great question, Nancy. Do I suggest taking collagen supplements pre-surgically? And thank you for your appreciation of what we do. I get asked that question a lot. You're right. Collagen is how the disc rebuilds itself after the surgery. So very insightful question. The annulus is made from collagen, and that's what's healing after surgery. I don't think collagen would hurt, but remember, all proteins that you eat, they go into your stomach breaks them down into individual amino acids, and then they're absorbed into your bloodstream, circulate through your body, and eventually make it to your disc. So would it hurt? No. Is it going directly to your disc? Absolutely not. It's going to be broken down into same amino acids from eating steak or anything like meat, any kind of protein-based food or vegetable that has protein. So you can do it, but I don't think it's necessary. I wouldn't spend a lot of money on it, but if it's cheap and readily available, go for it.
Last but not least, we have one more question from Big John on YouTube.
Big John, welcome back.
And they asked Dr. D, what is the tallest cervical spine surgery patient that will fit on your operating table? That's a good question.
All right, Big John, it's probably going to be you from the way the question is worded. I don't know. I think the tallest we've done is 6'5", 6'6", but we can accommodate, I'm sure, up to 7 feet. We don't discriminate based on height, and we'll accommodate you if you're that tall. I just don't have any idea how tall you are, but we've never not been able to do the surgery, and I'm pretty sure we've had 6'6", 6'5", 6'6". So.
And that is it for questions.
All right, I hope you enjoyed the surgery. Today is an exciting day. We have 3 surgeries today. You've watched the cervical spine. Next, we're going to move down to the thoracic spine. And then we're going to finish our day off with the lumbar spine. So you're going to see a cervical spine Deuk laser disc repair, a thoracic spine Deuk laser disc repair, and a lumbar spine Deuk laser disc repair, all in one day, right after each other. The thoracic patient is next. She's traveling to us from
Vegas?
I think, no, the last patient is from Las Vegas. She's from
Oh, no, yes, the last patient, California.
California. She's here with her husband. She has 5 herniated discs in her thoracic spine. 5. And we are fixing 2, the worst 2. That was her choice. That will be next. We're going from the right side, and we're going to do number 5, 6, I think.
5, 6, 7, 8.
And 7, 8. So we'll skip a disc or 2 in between. We'll be going in posteriorly. And for those of you who like to know this kind of stuff, we'll be coming in from the back. We go transforaminal. I'm going to make an incision in the back, and I'm going to come in right through that little hole right there around the ribs. Very hard to do. We're the only place in the world that does this. And people travel from literally all over the world for thoracic Deuk laser disc repair to fix their thoracic pain. All right, that'll be up in about 45 minutes. Thanks for joining us. I'm Dr. Deuk Majin. Don't forget, we fix hips, knees, and shoulders now without open surgery, without implants. So if you know somebody recommended for knee replacement or hip replacement, don't do it. Come to Deuk Spine. In 15 minutes, we'll have that pain treated with 85% average elimination of